I'm just going to wait for you all to arrive before we get going. Nice to see there's already quite a few of you have joined us, which is lovely. I'm going to just set up with my screen share while we are getting ready. Da-da-da. Fabulous. A few have in place already. Wonderful. I'm just going to open up the question bit. Oops. There we go. Right. Lovely jubbly. Right, I'll just wait a few more minutes and see if we've got other people turning up for us today. So just to kind of say welcome, obviously, first off, and thank you for coming. Really nice that you're all here. And I thought I'd put chat up. There's the chat. There we go. So let's just put, so you should all get, there should be a chat box. So you should be able to all be able to message me if you need to at any point during this webinar. I'd suggest if you have any major questions, keep them to the end. But if there's something that you're like, oh, I'm going to forget that midpoint, just message me in the chat. I will answer it as we go. That's absolutely fine. That's kind of what we're here for. It's not just about me telling you things. It's also about you asking the questions that you need to ask. So it's a bit of a two-way street, this really. Okay, so as we are at 2 minutes past, I'm going to get going. Okay, so today's talk is called Type 2 Diabetes Medication Titration. So it's about, is it time for you to increase or decrease your medication? And who am I to talk about this? So I'm Katie. I'm an independent nurse prescriber. I have a certificate in diabetes care from Warwick University. I am self-employed as a health coach. So me giving you this talk for free is one, for education purposes, because it's super important that people are educated in this, but it's also as a slight, like, actually I am also a health coach and I do help people navigate kind of the world of diabetes and health and management and that type of stuff. Okay, so that's a bit about me. Can one of you just say hi in the chat, just so that I know that I'm not, that I know that it works? Oh, wonderful. Thank you. Thank you, guys. Oh, phew. Oh, good. I'm so glad. And we've got someone on a question thing. Oh, wonderful. Ella's done it on a thing. Wonderful. I'm very happy that you're all there. That's good. It feels a bit weird doing it to a kind of empty screen. It is a bit strange, I would have to say. It does take a bit getting used to. So this is the second time I've ever actually done this talk. So I did it a couple of weeks ago. It was really successful and I had really good feedback. So I just was like, you know what? I had so much fun doing it. I am going to do it again, because that's kind of, you know, what we do, isn't it? So first off, I want to just work out who we've actually got here. Question, will we have the slides for your webinar? Unfortunately, you can't have access to my slides because I am getting them CPD accredited, which will mean hopefully in the future for nurses or healthcare professionals, they will be able to get accreditation for this, for coming to this. So I hope that answers that question for you, Ella. Okay, so first question, I just want to work out who we've got in the audience. So first poll is, we're just going to launch that poll, and it's just so I know who I'm talking to. So who have we got here today? We got nurses, doctors, people that suffer with diabetes. It's just so that I know who I'm talking to and I can pitch it right. That's all. Okay, I'm just going to stop that in 2 seconds, and we're going to stop that now. Wonderful. Right, so we've got a huge percentage of nurses because I have been putting this on some nursing forums, which is fabulous. I'm really happy to see that there is a doctor here. I'm really, really happy to see that there's people who actually suffer with diabetes, because that's who, you know, we all need to be talking from the same page effectively. I just, you know, that's, I think the real key is that not segregating what we all talk about. We all need to know the same information. Okay, so what are we going to cover today? We are going to cover factors that influence the need to increase and decrease diabetic medication. We're going to talk about the pros and cons of the different meds. That bit will get a bit kind of, there's a bit of a table, and we'll kind of go through all that. And then fundamentally, we're going to talk about kind of keeping it real, okay? Because that's the key, kids. That is the key. Got to be legit. Right, first off, blood sugars. So HbA1c is the kind of standardized blood test that we use to check for blood sugar control. Now, generally, if you're under the age of 65 and you have a blood sugar over the 48, I mean, this is for people who are already diagnosed diabetic. So we know you're diagnosed, but even if you have one over 48, this is really not good control. We really want to be aiming for blood sugar control below that to be getting the best outcomes for our patients. Those patients or people, you should be really aiming to be looking at having 3 monthly reviews. And that is really taking control of your health and taking control of what's going on. If it is lower than 48, that is pretty good. You're doing pretty well there. And I would just encourage 3 to 6 monthly reviews there, because that's where you want to be thinking about, is there other factors? The one that people talk about the most is about weight, which, you know, it's not the whole picture. Let's be honest. Let's talk about heart disease, cardiovascular disease. That's the stuff we need to be thinking about in the bigger picture. For people over the age of 65, we are looking at a slightly different picture, because everyone's blood sugars gets a little bit higher as they go through life. So we tolerate a slightly higher blood sugar. So kind of under the 50, over 53, we start saying, oh, okay, what's going on here? That's maybe not great. Under 53, good control. We're very happy about that. However, with good control, we always have to be very cautious, because there's always that thing of, you know, well, why are are your sugars so good because you're keeping them really low? Are you therefore having hypos? Are you then not going out? I mean, I used to have this lady that she didn't go out because she wanted her blood sugars to be so perfect. She was so scared of having heart disease and kidney disease that she wouldn't go to bingo. I'm like, go to bingo. Let's get that's about kind of quality versus, you know, quality of life versus really getting that blood sugars. These are not the figures that I'm referring to just diet. These figures I'm talking about even with medication. Sorry, someone's just add that on the question. So even with medication. So this is really what we should be aiming for if we're looking for long-term thing. Now, I do appreciate that those targets are exceptionally hard to achieve. So that's what we're going to talk about. Okay. So next thing, we're going to go into my another little poll, a little questionnaire thing. So this is Clive Owen, and Clive is 55 years old. He was diagnosed with type 2 diabetes 4 years ago. He's on metformin twice a day. He lives with his wife, his 2 children. One of his children's got learning disabilities. He works at an airport. He works long 12-hour shifts, 4 days a week, and he has 30-minute breaks twice a day. On his days off, he does childcare while his wife is at work. He smokes, he drinks, his nutrition is poor, no time for formal exercise. His HbA1c is at 52, EGFR, so that means it's slightly elevated for kind of perfection, but not bad. Kidney function, a little bit low, so it should be around the 90 mark. Urine ACR is 5, which we will come to a little bit later, but kind of means that his kidneys are feeling a little bit attacked, and he's got a slightly enlarged liver, and that's probably because he's drinking a little bit too much. And his blood pressure is slightly elevated. So normal blood pressure, you know, for someone that's diabetes, you're looking kind of like 130, 75 is really kind of picture perfect. And once again, you know, you've got to work on that a little bit, I would have to say. So second one, can I get up my second poll? There we go. Right, second poll, we're going to put this one up. So this is the question. What are we going to do at this moment with your knowledge, because we'll come back to Clive later on in the talk. What are you going to do? Are we going to increase his medication? Are we going to decrease his medication? Are we going to stay on the same? Or are we going to get more information? We're going to just give you a few more seconds here. 5 seconds to go. 2 and 1. Stop that poll. Wonderful. I'm just going to share the results for you. So, increases medication. So a few of you saying increases meds, it's an option, and it's one that we will talk through in a minute. Decreases medication, also an option actually, and one which we will talk through as we go through this thing. Stay on the same medication, potentially an option. His HbA1c isn't that bad, so I appreciate the people that are saying it's not that bad. It really isn't horrific, but actually if we look at the other side of that, his kidney functions dropping a bit, that liver function and that urine sample are all telling us that there's some kind of kidney stuff going on. So it's maybe worth us thinking about the other side of things, the kind of the bigger picture on that. Gather more information. I'm totally up for that. So that's kind of my little beginning thing. So up, down, stay the same. So let's just talk through these. This is really a kind of a talking for us to kind of talk through times to increase medication. Okay, high HbA1c. Yeah, you want to be looking at, you know, it's not great to be having a high blood sugar. We are well versed in knowing that there is kind of long-term consequences to high blood sugars that can affect our kidneys and heart, you know, nerves and all that stuff. Hopefully you that are coming on here, that's another talk for that I do about kind of what diabetes is and the side effects. But for this one, we know, yes, high sugars, it's not ideal. Times to increase medication, more sedentary. So COVID has been a perfect example of this. We've had a huge change in people. Suddenly they're not walking to work, they're not getting the bus, they're sat at home more, they are not, you know, walking to the pub even, you know, because that, to some of our patients, that is the only exercise they were getting. So they have become much more sedentary. That is a time to be talking about that and saying, well, you are sat down a bit more. Should we be thinking about, you know, what's going to happen? Increased stress that you can't reduce immediately. So what I'm talking about there is realistically, stress increases blood sugars due to cortisol levels. And therefore you might find, you know, I had this lady, her mother had died, and the knock-on consequences have meant that there was huge family fallout. Her blood sugars were terrible to be controlled. So that's that kind of thing of digging in a little bit deeper, that kind of gathering information, because that stress level can really play a huge impact in blood sugar control. Okay. Pregnancy or prenatal, it's really important that we prenatal, get them on folic acid. We'll love a bit of folic acid, but for pregnancy, you do want to be over kind of, you know, pregnant women do have a tendency to be like, oh, I'm a bit cautious. Get them on that metformin earlier on, get them on the insulin earlier on. I mean, luckily, you know, as practice nurses, we don't really tend to have to do that very much. You know, the kind of maternity midwives take that over. Erectile dysfunction and sexual dysfunction. Now, basically to get down, we need good blood flow. And to get good blood flow, you really need lower blood sugars. Now, this doesn't just apply to men. You know, that is one of the most common things that we talk about it with men, but actually for women, there is increasing evidence coming out around kind of reduced libido, vaginal dryness, and also because of now kind of adding in SGLT2s, we're seeing a huge kind of sexual dysfunction through the fact that everyone's having urine infections and thrush. So that is maybe a time to be questioning, you know, do we need to increase the medication, but potentially do we need to change the medication? Because are we actually causing other problems in their life? You know, I mean, speaking as a woman, if I've got any issues down there, there's no way my husband's coming close to me. So, you know, we have to be thinking about the human that's in this, not just the medication side of things. And kidneys and heart issues. Now, you know, as we saw with our sample, our case study, Clive, earlier, if your kidney function is off and your blood pressure is elevated, even if your diabetes control is pretty good, you are starting to show signs of macrovascular complications and microvascular complications. That is the big posh words for saying heart problems, kidney problems. Now, that means that those those organs are becoming under stress, and that stress can be exacerbated by long-term diabetes. Okay, so that means we do need to be thinking, right, medications might not need to be increased, but might need to be altered, and thinking not just about diabetic medication, but, you know, getting people onto ACE inhibitors, you know, ramipril, things like that. But even thinking, you know, adding in early other things like beta blockers or calcium channel blockers if required. So those are all blood pressure medications, and sometimes we do have to be thinking about that type of stuff. That doesn't mean that we don't want to think about lifestyle factors, and lifestyle factors are really key in a lot of diabetes management and diabetes control, because diabetes, you know, fundamentally we can help the management through kind of exercise, which will increase our insulin sensitivity, and by reducing the kind of sugar content that's coming into the body. So we can make huge impacts with our diet and lifestyle. Now, another thing to think about here is actually holidays, Christmas holidays, and Ramadan. I've put Ramadan on the decreased time, but actually I've had one or two where we need to increase during Ramadan, and that's, you know, it's perfectly okay to have a temporary increase of a medication. So I have had a patient who has been very honest to me and said, look, I'm going on an all-inclusive cruise. I'm going to eat. I love eating. I love my all-inclusive cruise. I don't want to take that away from, you know, the holiday. I don't want to take that away from my partner. Okay, cool. Let's just increase some meds temporarily. You know, for that patient at that time, they were already on a low dose of glycoside anyway, so just made sure they had enough blood sugar machine stuff, and we did some slow increases of glycoside for while they were on that holiday. And it just meant that we, rather than having that big spike of the holiday and then back down, we kind of smoothed it out a little bit. How many times do you hear, oh, it's because of Christmas, oh, I had a tough Christmas? And you know, there's no harm in saying to patients, look, if you know you're going to have a bad Christmas, why don't we just like add in a little bit of this, or, you know, sneak a bit of that? I've even had patients, as they've reduced their metformin, what they might do is on days that they are more active, not that they're eating more, so on, like, say, Christmas Day, they might take an extra metformin because they know that they're increasing their sugar intake on those days. And I guess that's a lot of what my talk to you today about, is kind of about being very patient specific or person specific about what the, you know, what your lifestyle is. It's got to be reflective. This is, you know, medication is not one size fits all by any means. So we have to be willing to kind of play around a little bit with those meds. So times to decrease, okay? Hypos. So hypos is when your blood sugars are dropping, and they can happen for a multitude of reasons. Too much insulin, too much exercise, skipping meals, all sorts of reasons. A lot of the time, if someone's having a lot of hypos, you do need to be questioning further. Why are you having those hypos? Let's explore those a little bit further. Sometimes it might not be that you need to decrease the meds, but you might need to just move the time of the medication. And that's absolutely fine to do. An increase in physical activity. So one of my patients, she was getting hypos every day she went swimming. So as a result of that, we actually halved her metformin on the days that she swam. And then the rest of the time, so she went down to a 500 milligram dose on the days she swam, and she was on 1 gram on the days on her inactive days. And that way she actually managed to keep herself hypo-free, but also active. And, you know, that was a perfect choice for her. Weight loss, yeah, definitely a time to decrease. I mean, you know, I don't know if as nurses or doctors that are in the audience today, how many of you are using GLP-1s, but we do, you know, as that weight drops off, which is fabulous, you do need to be thinking, right, this person now we need to get some off some of the meds. Otherwise, this person is going to start not taking their medication because they're going to start feeling sick. They're going to start having hypos. So a lot of this is around kind of conversation. You know, it is just having those conversations. Decrease in active days, like I said about that lady earlier. Ramadan is a really interesting one because you have two, you know, basically you've got 2 times that you're breaking for fast. So you've got iftar and sari, which I'm so sorry if I've pronounced those wrong. But effectively, you know, if you were thinking about, say, you know, normally people who take their medication in breakfast and tea time, all you're doing is really flipping it round to iftar would effectively feel like tea time, and sari would feel like breakfast time. So you're just kind of switching the doses round. For some people, switching to a modified release during Ramadan is a great option, because they will say, I forget to take it at the dawn break, because they're half asleep and they're knackered. Absolutely fine, switch it to a modified release. And I think some of that is about having the conversations with your clients, but also for those who are patients in the audience that have diabetes, it's also about you having those conversations and saying, look, this is really what's going on in my life and this is what I'm experiencing. It's a bit of a two-way street, so to speak. Specific diets like intermittent fasting and the Cambridge diet, which there's lots and lots more information coming out on. That is, once again, I do a different talk about diets and diabetic diets, and that is a whole other ball game. But yes, it's time just to be mindful. Side effects, so especially things like, you know, GLP-1s do cause a lot of side effects. They cause a lot of kind of gastro side effects. So just be mindful of that. I just want to add a little note here saying that, you know, if we are bringing someone's blood sugars down, nerve pain can increase, okay? And so if you have got someone who's had a very, very high blood sugar and you've put them on a whack of glycoside to really bring their blood sugars down, it is worth checking in about pain, and are they actually suffering with pain as a result? And it might be that they don't need a long-term course of, you know, anything. They might need kind of exercise to reduce the pain, a TENS machine. Some people do need something like a pregabalin or a gabapentin, and it doesn't need to be permanent. It can just be temporary. Okay, so I found this picture off a student forum, which I thought was marvelous. And it was kind of this the untold story, you know. And I think it's just such a good reminder for kind of for me as a nurse, but also I think, you know, we are also patients, you know, as you know, as nurses, we are patients, and we also have I mean, like, I take medication for asthma, and I can look at this and think there's, you know, I definitely can look at that and think, actually, there's definitely times I don't take my meds because of side effects, lack of privacy, pharmacy issues, definitely. So when it comes to the patients and having those conversations, it's really key to kind of keep in your mind that actually there's a whole myriad of what's going on underneath. And you know, a lot of the time, especially from a nurse point of view, you know, you're sat in your room, you've already got the blood results, you've looked at your last few consultations, you think, I know what's going to happen here, I know that they need this drug, or I know this result, and you already have an agenda before they can walk into the room sometimes. And that is a detriment, it kind of can be a detriment to the consultation, because it means that you can maybe miss the untold story. And yeah, it's just a little reminder, really. So this is just my little thing of saying, keep it real, kids. And what is your lifestyle really like? You know, we've got to be honest. For my case study patient, he's a airport worker. He works 12-hour shifts. You know, his routine and things like that is going to be really up and down, and it's going to be quite challenging in terms of getting his meds, remembering his meds. And then, you know, he's got kids that are disabled, he's managing a home life. There is no way that someone like that is not going to be missing medication. Or and if they kind of say, oh, I take them all the time, you think, One of my tricks that I used to do, it's not a trick, it's probably the wrong word, but one of my kind of communication tactics with this I would ask patients, say, you know, I know I've got your meds on the screen, but I just want to run through what you're actually taking. I just want to run not actually, that's the wrong word. I want to know what you're taking, what meds are you on? Or I might say, like, oh, the computer's being really slow, just could you run through with me? And actually that is a great way to work out what is actually being taken and what they understand. Oh, we got a hand raised. How do I find out what a hand raised is? Someone's just put a hand raised and I don't know how to deal with that here. Not sure. Whoever just did the hand raise, if you go on the chat at the side and just type your question, there should be a chat box. Then please do put your question in there. That would be great. Okay, so I'm just going to bring up, we've got another poll here. So I'm going to just launch this poll. So what barriers do you feel are affecting good patient to healthcare professional relationship? Now, this is a multiple choice question. I want you to just have a look, you know, choose what you're coming up with. So we've got time, too much to cover, healthcare professionals don't care, patients don't care, honesty, privacy, lack of education for healthcare professionals, lack of education for patients, or mentally being busy with other things. I'm just going to give you 2 more seconds, and 2, we're going to stop there. Okay, I'm just going to show you those results. So as you can see, the big thing that people really focus on there is time. And I mean, yeah, I completely agree. It is really frustrating. There is no other words to describe how it is. It is frustrating. Some of the things that you can do is just kind of, I guess, having words with kind of practice managers or who your managers are, and just saying, look, this is not realistic, because actually for diabetes or for any long-term condition, you know, really we need to be thinking about not just like, here's the med, off you go. You've got to be thinking about kind of behavior change and like what's going on. You know, it's a much bigger thing than just our consultation style. It's not just that we're not effective enough. That is not the rule that I found working with nurses. Nurses generally, if they have the time, they are fabulous at what they do. But yeah, it is an issue. Some of the things you can do are just kind of around the kind of language you use. Like I said, about not kind of having an assumption. So I'll sometimes print out the graph of the HbA1c and just kind of get it ready and then say, so I can see there's been an elevation over the last 3-6 months. And, you know, there's been an elevation. What's going on in your life? And then stumm. And that's hard. It's hard to stumm. It's very hard to stumm. I do appreciate whoever from Zoom user. I agree. I hope all other panelists can see that. I don't think they appreciate it. It is hard. Long-term condition management is hard. And I think that potentially this is where we will see the rise of health coaching in the UK, which I'm a big advocate for, because actually it is much more complex than a 20-minute appointment. You know, the work that I do with my clients, I do kind of behavior change models and motivational interviewing and things like that. And that is really key to being able to have a long-term success. And I'm hoping it will change in the future, because it is very frustrating. All the other things, I complete every single one of these answers. You know, I wrote them because they're things I've experienced and felt. You know, sometimes we are too busy. Sometimes it feels like we don't know enough. Sometimes it feels like patients don't know enough. It's very challenging. So if you're working in that field, or you're a patient in that is experiencing that, we all have to just be so much kinder to each other about what is going on, because it's a tough world. It's really tough. Okay, we're just gonna move on. So this is kind of my theme of the talk, is about being a stable table and being proactive to the lifestyle. So being responsive to the person rather than, you know, oh, it needs to be this way or that way. It's about being responsive and kind of going, okay, this is working, this isn't. Your lifestyle's changed, cool, let's change your meds. That's absolutely fine. Okay. I would just like to point out that I've used some slightly different language here on my stable table. Rather than diet, I've used the word nutrition, because actually diet can really tell people that they need to be on a restrictive pattern of food, maybe not always appropriate. It's really about increasing nutrition and having the correct nutrition for that client, and body movement rather than exercise, because a lot of people who have bigger bodies have a lot of fitness resistance, because they've experienced really bad times when they've been kind of, you must exercise. So sometimes changing that language can really help engage your client in a different way. Okay, so this is just, I've kind of nicked this off of one of the current American, so in 2020, so the NICE guidelines, which are from 2016, are a little bit out of date, and really we're all kind of following the new American European guidelines that have been mashed together. So those, I just wanted to point this out on here, that says basically adding in medication, so putting in something like a GLP-1 or an SGLT2 can be done independent of whether or not their HbA1c is high. Okay, so if they have cardiovascular disease, kidney disease, or at risk of those things, you could be thinking about adding in an SGLT2 or a GLP-1, even if the HbA1c is kind of fair to good. And that is because we are thinking about the preventative, the long term, about kind of what is really going to be happening to the heart and kidneys. And it might well be that you bring in an SGLT or a GLP-1, and then as time develops, bring them off something else. But fingers crossed, in the process, you're hopefully protecting kidney or liver, kidney or cardiac function. Obviously, we'll talk about SGLT2s and kidney function in a moment. Okay, this is the current kind of the guidance, which, I mean, presumably you'll all have it laminated and stuck to a wall if you're a patient, if you're a nurse or a doctor. If you are a patient, it just looks overwhelming and feels a bit scary. So I've kind of put it into just me talking about it because I think that's easier. So metformin, we love metformin. Metformin is a great drug. It is tried, it's tested, it's been around for a really, really long time, and it does wonders. It is a hug for your heart. It has really good kidney and liver protection levels. You can use it a really long way down into the kind of kidney function markers. It's good to use. The other thing is you've got 4 tablets, okay, that you can play around with. Not just 4 tablets, but I mean, like, if you can be taking metformin once a day, twice a day, 3 times a day, 4 times a day, you could be taking modified release. All of that means there's a lot to play with, okay? So like I was talking earlier on with my lady who would get hypos when she went swimming, playing around with that metformin meant that we could kind of be a bit more open. I've had clients who, what I've done is taken them virtually all the way off glycosides and things like that, and got them, because I've been using GLP-1s, which I've had some great successes with using those GLP-1s, bringing down the other meds, but I would still keep them on a metformin, because that metformin is going to give us such a good cardiac protection. There's so much more evidence-based behind it. So, it's our first line therapy. I know that there's a temptation to be rushing onto the other drugs. Yes, but actually metformin is a beautiful drug. It is well tolerated. For those that it's not well tolerated, it's cool, man. Try something else. Okay, this is my big scary looking slide, and it looks a bit kind of back and forth. And this is really me breaking down the different drug groups, and we're going to run through the pros and cons of these. I'm just checking the time. So we've got the sulfonylureic. So these are your glycosides, okay? Glycosides are actually pretty good because they bring blood sugars down really fast. So perfect for, if you've got someone that's got really high blood sugars, they're newly diagnosed, I might actually start them on a glycoside over starting them on a metformin. Will we get the slides? Francis, unfortunately, I can't give you the access to these slides because I am in the process of getting them CPD accredited. So then they will, I don't quite understand. So I'm new to that whole process, but I'm in the process of getting them accredited. So I think they come under as then an intellectual property, and then so on and so forth. So, but please take a photo while you're here, go ahead, take a photo. So yeah, sulfonylureics are great for that. Great for steroid use. Patients who are about to have chemo and they're about to go on some dexamethasone, or your COPD patients that are about to exacerbate or exacerbating, get them on some short-term glycoside. There is a Scottish guidance for that. If you just type into Google like glycoside titration for steroid use, it'll come up, and it's quite a useful one to follow. It's a little complex, so give yourself a bit of time to read it, but I mean, the rule of thumb is you kind of like start them slow, start them on a 40 milligram and monitor it, and if the sugars are getting higher, add in a bit more their blood sugars. So that's the thing with glycoside, you do want to be giving them a blood sugar machine, especially if you're titrating over a short course of steroids. Same for things like people who are going through Addison's, things like that. So yeah, steroids, definitely want to be thinking about using a glycoside there. They are super cheap. That's typical, my sister phoning me. They're super cheap, so doctors love it when you use them. One of the negatives to them is they release insulin continuously. So they have a really high hypo risk. So that means they are not great in that kind of over 65 population, because you want to avoid those hyper risks. You don't want people to fall. You don't want to, so if you have people that are on glycoside and they're well established, yeah, leave them alone. But if people are starting to have wobbles or, starting to have any symptoms, that's the one you want to be looking at first, is should I be getting them off that glycoside? You do need to have a blood sugar machine, especially if you're driving. The current driving rules are really that it's a little bit, they changed it. It used to be if you were on an insulin or an sulfonylurea, that you had to have a blood sugar machine. You had to check it 2-hourly, before you left, and every 2 hours that you're driving. That is now just for insulin. For sulfonylureas, it's just saying that you should inform the DVLA. So the rules have slightly changed. It's not as strict with sulfonylureas. However, I still think that there is an argument there for saying, just be mindful. There's no harm in giving people that little bit of caution around them. One of the negatives is that they can cause weight gain. So if you have got a client who's sat there saying, oh, I can't get my weight down, well, there is better drug choices potentially for that person. I'm going to just keep going through all the pros and cons. I've written down at the bottom what you can mix, the drugs that you can mix choices with. There's only a few that you can't really mix, and I've written them in bold, not to mix with. I've put not under diabetic centre or Manchester diabetic, because I'm based in Manchester. Pioglitazone, so super cheap, used to be used all the time. However, I see more cons than pros, and I actually went through a bit of a mission, and I took virtually all of my clients, all from the practice that I was at, off pioglitazones and moved them onto other things because of the risk of heart disease, heart failures, increased edema, and weight gain. It just kind of felt really counterintuitive. If you as a patient or if you as a nurse kind of think about this, it is a really great little audit for you to do. Or if you're a patient, it's a great one to go to your GP and say, look, I'm not comfortable on this drug. It's a little outdated now, and we've got better choices. Your DPP4s, so your sitagliptins, linagliptins, valagliptins, all sorts of those ones out there, brilliant for kind of weight stable patients. So they do happen. I know that we kind of have this huge association that all type 2 diabetics want to lose weight. Not everybody does, and not all of them need to. So your DPP4s are great for that. I found those most useful in people with kind of learning disabilities, so who aren't great with kind of multiple meds. So metformin can be quite challenging because you've got 4 tablets a day sometimes. So, putting someone on a linagliptin that I know that they're not going to chop and change, because linagliptin, you can keep that all the way down to the EGF's very low, which is great if you've got, say, someone who's autistic and doesn't really like changes of meds. You want to be picking that medication choice early on as something that they're going to feel comfortable and it's going to stay. So linagliptin is a great choice for that, because you can stay on that to an EGFR of 15 and it's just once a day. And generally, that is much more tolerable than saying, oh, we're going to try up and down, up and down. It's a great choice. They are a bit pricey, though, just to be mindful. But if it's the right choice for the person, it's the right choice. Your GLP-1s, I mean, if you're a nurse and you're working in this industry, you will know, there's a lot out there, kind of a lot of hype going on. They are fabulous. They do help a lot of weight loss. And we now have this new oral one, which is fabulous, because the injections can feel, quite a lot of time consuming. Except for the injections, you also get, there's funding, there's injection funding around that. So you might find your GPs prefer for you to stay on doing injections rather than tablets. They are quite expensive. They do have a lot of side effects and symptoms, and you do need to do a lot of education around them. because effectively what's happening to the body is that they help with insulin sensitivity, but they also reduce the speed at which the stomach empties. So you feel fuller for longer, which is part of the reason why they work so well, you know. So you've got this, you know, they're working on the pancreas, making that pancreas work a bit quicker and produce more insulin, but it's also keeping that fullness. So you're going to get kind of nausea. Some people vomit, some people get diarrhea, some people get constipation. If you do not educate, you are going to disengage them from that drug group. And actually, if their key aim is for them, or, you know, is really, I need to get my weight down to prevent loads of diseases, it's a real shame to not educate them properly on those side effects, because you don't want to disengage, because people do. As soon as you've had a bad experience, it's very hard to try that drug group again. SGLT2s, once again, weight loss, cardiovascular protection, beautiful in lots of ways from that point of view. These guys work on the kidneys, not the pancreas, okay? So they work in a different way to virtually all the other drugs. Historically, that's why they said you shouldn't, that's why they kind of mix with virtually every drug. Nowadays, I will put people on GLP-1 and SGLT2. But that is because I'm prescribing it. If you are not the prescriber, it depends on who is the prescriber, and if they are comfortable to do that. There is more evidence coming out that there's no harm in that, but it's just because the reason for that is because they're just quite new. Once again, like I was talking about with sexual health stuff, it's just about education, about kind of making sure that you're not having too many urine infections, too much thrush, all of that type of stuff. Insulin, once again, that is another talk that I will be doing, because about insulin starts and things like that. Insulin is a fabulous drug, and it is, you know, I think it's something like 95% of patients end up on insulin anyway. It's something bizarrely, stupidly high like that. And they are fabulous in that you can really monitor things a lot more closely. The kidneys are safer, the liver is safer. They're great. There is issues. People have a real psychological fear around insulin. Yes, there's potential for weight gain and also getting lipos on the stomach. You need to educate, you know, BM machines, they need to be literate. There's lots of issues. So one of the arguments for insulin is actually bringing it in younger, because actually by the time that, you know, you've got someone who's got lots of health problems and lots of health disease, you know, then saying, oh, now we're going to add in this really complex drug where we've got to really, it's just going to feel really mind-boggling. So there is an argument for bringing it earlier. I do well know the challenges around that, and that is just one of the things. Sometimes it is about planting that seed early in your kind of conversations with the patients. You know, I might say it 2 years before I anticipate them going on insulin, just to kind of plant the seed, like, oh yeah, well, you know, at some point, obviously, well, when we're talking about insulin, you know, when we think about that, as if we know it's going to be coming. Okay, I'm conscious of the time, guys, because I don't want to take up extra of your time. Kidney function. This is just a slide of the kind of how we diagnose kidney function, and at the top there's the EMIS codes there for kidney function. So just never forget kidneys. This is just talking about kidney function once again, and I think I went through a few of them there on that slide, which basically is saying, you know, certain ones are really great. So your metformins are obviously really good for kidneys. Your DPP-4s, certain ones are fabulous, like your linagliptin can go really, really low. Most of the other ones you need to titrate. Your SGLT2s, basically, you know, you don't want to be starting them if they've got an EGFR lower than 60. They used to say not to be used below 45 EGFR, but actually that's not really the case anymore. That, you know, people are using them a lot lower. but that is really up to the prescriber, who is just making that decision. Sulfonylureas, once again, can be great because you can actually use them quite a long way down into the kidney disease process. And that is the biggest argument for pyroglycozones, is you can use them all the way down. And that is why they are still on the market. And that's what they are predominantly used for, is in that kind of later stage. GLP-1s are not great with any kind of kidney and liver issues. Insulin, we love insulin. Okay, so we've only got a few minutes left. We've got 10 minutes left, so I'm going to just come back to my next poll. We're going to come back to our chat. So, having gone through all of those things, okay, we're going to just come back to Clive. So I'm just going to move that over there. So Clive, so we've gathered more information. That's what we're just putting on here. And actually, he is only taking his metformin once a day. So he's on one gram of metformin twice a day. He's only actually taking it once a day. Also wanted to add in, through kind of information gathering, he has actually also got some erectile dysfunction. So what do we think the best choices are? So please go ahead and vote on that poll. We have got there some really good answers. Yeah, switching to a modified release, reduces metformin, adding a second therapy, adding an SGLT2, great. I'm just gonna, there's a couple there at the end that, sorry, if you scroll down, discuss referral to social services, I've put in there as well. Congratulate him on his good health. So let's just I'm going to give you 2 more seconds and we're going to end that poll. Okay, I'm just going to bring up those results. So effectively, most of these could potentially right answers, actually. And it's about looking at that bigger picture. Switching to a modified release is potentially a great option for this chap, because actually, yeah, he is obviously struggling to remember. However, given he's got that, that slightly high blood pressure, I would be thinking about putting him on an SGLT2. Because his blood pressure is slightly elevated, we know that SGLTs work on the kidneys, and one of the things that they do is have a very similar effect to like an ACE inhibitor, like a ramipril. And if he's already someone that's struggling to take meds, I would maybe think about putting him on, basically reducing his metformin to once a day and then adding in an SGLT2 at the same time. You know, it's a trial and error thing, and it would be fundamentally how your patient would feel about that, but that might then have a positive effect on his kidney function, and his, because at the moment his EGFR is fine to add in those drugs, but his urine ACR, so he's showing some signs of leaking protein, so effectively his blood pressure is too high. I would definitely be talking to him about what's going on at home, because actually, you know, that's why I put in that social services thing, because actually he might need some support. Him and his wife, you know, they might actually need some, you know, outreach support. They might need respite, and that actually might be really what helps. Advise him on lifestyle choices, definitely. You know, this guy is making some bad choices, let's be honest, he really is. Of course, I put in there support from a health coach, because that's kind of what I do. And that's really where, you know, working on lifestyle coaches, lifestyle stuff, you know, that's what health coaches do. We have we have more time to really focus on that and really bring down what's actually going on and work on those things. Start my blood pressure meds. Yeah, we need to sort this man's blood pressure out. He is heading for a stroke, and that would definitely need to be looked at. So yeah, hard to do all of that in like a 10 to 20 minute appointment. It's tough. So these are my references, guys, and I'm just gonna run through these. Are what I hope you've got from this today is that you need to be responsive basically to the client. Doses are going to go up and down throughout life. It's cool. The key is not to be frustrated by yourself or by the patient for why it's not working, because you know what, it probably won't a lot of the time, and that's okay. And it's about having that rapport and that relationship of saying, okay, it didn't work this time, let's try something else. What else? You know, and kind of being a bit like a detective about where to optimize things. Being honest to yourself and the healthcare provider, you know, or as a nurse, being honest to your patient, and encouraging that kind of honesty and rapport building. Understanding medication reduces fear. That's kind of what I wanted to bring from this today. What we've covered, just to recap, the pros and cons of the meds, and this is me. So I am basically just wanting to open up the chat and basically say, do you have any questions? That's my email address. I've actually, from my last talk, I've had some nurses email me and ask me questions, and that's been really nice to just kind of, you know, about specific patients. Please feel free to do that. I'm very happy for you to do that. I will be producing kind of more talks and things like that over, you know, as time goes by. You know, I'm new to this world, new to this field. So, you know, and yeah, so if you want to know what's coming up, please follow me on social medias. I know we all follow a million people on freaking social medias. But yeah, what I'm all about is kind of working out, you know, helping people whose their weight is affecting their health. And eventually I'm training as a personal trainer as well. So I will be doing low impact exercise classes and chair-based classes online for patients and clients. So that's kind of who I am. Is there any questions, guys? I hope that you've all understood and got things from that. Thank you very much. Thank you all for saying thank you. That's really sweet of you. I really hope that you did get things from it. I'll just give you a few more minutes and see if there's any questions about meds or about a patient. It was really good. Thank you. You're very welcome. Very useful. Good. I should really record this. I should record these little messages so that I can remind myself when I'm having one of those days. I'm like, what am I doing with my life? Fabulous, useful information. I'm really glad you've all enjoyed it. Wonderful. Well, it is basically 8 o'clock. So I just, yeah, if you do have any questions, any further follow-up, just genuinely message me. I am really here to help. I'm really here to, you know, help kind of healthcare professionals and patients in the world of diabetes and that kind of world. Thank you. Could I see the slides for kidney disease? Yes, I will go back to those slides about kidney disease. There you go. That's the one about the dosing. If you just want to have a quick snappy snap. Yeah, it's a bit of a shame. It's hard because there's so much to cover, you know, and this, no wonder our patients, you know, we don't have enough time really with our patients. There's so much to cover. It's just ridiculous. I'm really sorry, Amanda, I can't send you the slides because I am getting them accredited. I'm going to get myself accredited so that you can, in the future, I'll be able to give CPD points. That is the plan, but I've got a few more courses to write. It turns out you've got to write a lot of courses to do that, and I have never done this type of stuff. The person who said with hypos, were they only on metformin? So the person that was having hypos with metformin, yes, they were. So the one that was going swimming, yes, she was just on metformin and going swimming and getting hypos for that. You know, it could be for different people, different things. I think she was just such a lovely lady. She was really pushing herself. In the end, we kind of really brought her to the point that she was only on 500 milligrams of metformin because she just was working on it really, really hard. So, you know, that was good for her. I thought metformins can go to hypos. They really can't, but if you actually speak to people, they say they will. And that is, you know, partly we don't really know what makes metformin work. We think it increases insulin sensitivity, but there isn't really, no one really 100% knows. What's probably happening with her is that she was taking her metformin, not having a breakfast, and then going for a swim. So, you know, not having a breakfast, she's not got any food in her, and then she's having a swim. She's then increasing her insulin sensitivity. So she was doing a double whammy of things. So you know, for her, I don't want her to stop swimming. So, because that is the most natural form of a solution for her. So yeah, for her, I just kind of, that's what worked for her. And that's that thing of, you know, the literature, you cannot really completely take it at face value. You know, patients will tell you time and time again, like, that's not what happens. That's not what happens to me. You're like, well, all right, believe them. You know, it's their body at the end of the day. Believe them. Yeah, I hope that answers that question for you, Catherine. Yeah, I hope that does. Any other questions? Fabulous. Okay, guys, well, I'm going to stop and we're going to log off now. And just want to say thank you all so much for coming. It really does mean a lot to me, just because I'm learning skills, I'm keeping myself on my toes, and it's good to do. Okay, my phone is telling me it's time to stop. Okay, guys, take care. All right. And thank you again for coming. Okay.